good morning and good afternoon, everybody around the globe, and very welcome to the 14th Brian Warren School of Pathology. We are very pleased to have the school live again. Unfortunately, this year, schools turns to be online, but hopefully we will come back to the real meetings next year in 2022. This is 14th school, but the school has been existing now for 15 years, thanks to the joint efforts of the Bosnian pathologists and with the great help of the British division of the International Academy of Pathology. We are very helpful for BDIP for all their great support that they have offered to the Bosnian pathology community all these years, especially for making this great event possible in the previous 14 years. I also want to appreciate their great support not only to this event but to other educational and teaching activity for the Bosnian pathology community. As you know, this school has the name Brian Warren School. It's in the honor of the great British pathologist, GI pathologist, Dr. Brian Warren, who passed away 9.5 years ago and who's initiated this school in 2006. Next year, we will have a 10th anniversary since he passed away, and we will celebrate, on the other hand, the 15th Brian Warren School of Pathology. This year we have a distinct topic again after 10 years because we had a soft tissue pathology in 2010 and we are getting this topic again in this year. It was planned for 2020, but because of the global pandemics that affected all us around the globe, we had to cancel the school last year, but we are running the school again this year with two distinct British speakers, but renowned internationally as experts in soft tissue pathology. It's Professor Cyril Fisher, who is a emeritus professor of tumor pathology and consultant histopathologist from the University Hospitals Birmingham and the Institute of Cancer Research, University of London. And our second excellent speaker today will be Dr. Kim Tway, who is consultant histopathologist and reader, which is equivalent to associate professor in translational pathology from the Royal Marsden's Hospital and the Institute of Cancer Research, University of London. As you know, this huge and a very important topic of soft tissue pathology most practicing pathologists occasionally deal with is very challenging and huge and very important topic for in the surgical pathology. And I'm sure these excellent speakers will provide you with new insights and practical skills that will help you in solving out these important practicing issues in everyday diagnostics. So once again, I wish to thank you for joining this big event and big meeting this year, and I acknowledge the efforts of our organizers, local from Bosnia, and of course BD, and to our UK speakers. Now it's the Dr. Cyril Fisher, who will start his two sessions related to the diagnostic approach and mimics of soft tissue tumors. Once again, welcome to the 14th Brian Warren School of Pathology. Thank you.
Good morning, good afternoon, everyone. Thank you very much, Samir, for that very kind introduction. We're very proud and delighted to be invited to be giving this seminar this year. This is my and Dr. Sway's first visit to Bosnia, sadly only virtual. Perhaps next year we'll do something more real. Let me introduce you to the program today. If I switch to the screen. So we have a full program today, which consists of 8 lectures. Now, soft tissue tumors are very rare, probably 1% of all cancers. They arise anywhere. They're seen in general surgical pathology practice. There are at least 100 subtypes. There are 121 chapters in the WHO book, many of which have variants. So there could be 200 or 300 different tumors to choose from every time. and they can mimic other tumor types, carcinoma, melanoma, and lymphoma. Therefore, it's necessary for any general pathologist to be aware about soft tissue tumors. The other issue with soft tissue tumors today is the spectacular advances in molecular pathology. Now, we're not all molecular pathologists, but we all need to know a little bit about it, and that applies to all subspecialties today. If you don't have your own molecular diagnostic facility, you should have access to a regional or national one. And it's important to know when and where to request molecular tests, to be able to understand the report, and to convey the relevant useful information to the clinicians, which is our function after all. So I make no apology for these presentations being updated to include a lot of molecular data, much of which is emerging and may yet not be clearly significant. But I'm also aware we have a mixed audience and that many people are not highly familiar with the huge range of soft tissue tumors. So I'm going to start by talking about my approach to diagnosis and how we can all look at tumors to get the maximum information out of them. Then I'll talk about mimics, and then my former colleague, Dr. Thway, will talk about fatty tumors, tumors of uncertain differentiation. Then after lunch, or whatever it is in your time zone, I hope at least be a break, we'll talk some more about spindle cell soft tissue tumors, EWSR1 rearrangements, and then Dr. Thway will deliver 2 presentations on small round cell tumors and epithelioid tumors. So we're covering quite a lot of material. There is not capacity in a day to cover the whole field of soft tissue tumors. The WHO book is very thick, and there are many, many entities. But I'm hoping we'll give you some information or some, at least, method of approaching this, and you will have some awareness of the range and type of tumors next time you see one. So let us begin then with my approach to diagnosis of soft tissue tumors. So how are soft tissue tumors classified? Well, the WHO, of course, consensus from 2002 and repeated in the subsequent editions, classifies them by differentiation. Now, this means the type of tissue the tumor is trying to form. And this can be one of many mesenchymal tumors, as you can see listed here. We no longer talk about histogenesis or cell of origin because we don't have cells of origin. And because many of the tumors are translocation associated, these are actually new cells with new genetic makeup. So we can only detect diagnostically the tissue the tumor is trying to form. But in each of these subtypes, there can be also many different types of tumor. For example, in liposarcoma, we have well-differentiated and dedifferentiated. We have myxoid and the higher grade version that used to be called round cell. And we have pleomorphic. And these are all liposarcomas. And of course, interestingly, all of these have their own distinct genetic makeup. In addition to the tumors with a certain lineage, there are tumors with uncertain differentiation. And these, interestingly, have historical names that we still retain, based mainly on the description, the way it was interpreted microscopically, or by the location. And many of these actually have non-mesenchymal differentiation, such as epithelial, melanocytic, mesothelial perhaps, myomelanocytic, and so on, even though some of them we do not know what lineage they're attempting to form. The second arm of the WHO classification is by behavior. So tumors are divided into benign and malignant, that's sarcomas, and also a large group of intermediate tumors, itself divided into locally aggressive and rarely metastasizing, rarely being usually less than 2% of the cases. Of course, the majority of soft tissue tumors are benign, and these are the common ones. And we have intramuscular lipoma, schwannoma, intramuscular myxoma, intramuscular hemangioma, and you can see these are very straightforward and easy to diagnose. This is more difficult. This is an example of nodular fasciitis, and I'll be talking in some detail about that later. But these 5 or 6 tumor types with leiomyoma actually comprise the commonest benign soft tissue tumors. So most of the ones you will see will be benign. Now, intermediate tumors, as I mentioned, are divided into 2 categories: locally aggressive, and here's some examples of those in different categories of differentiation, atypical lipomatous tumor, and so on. The type example of that is fibromatosis. Fibromatosis typically occurs in the muscle. You can see on the left here, this is the abdominal wall of a recently pregnant female, which is a very typical presentation for desmoid type fibromatosis in this age group. And histologically, it's characteristic with these parallel aligned, evenly dispersed myofibroblasts in fibrous tissue with split-like vessels, little spaces around them containing mast cells. And this can recur locally, but does not metastasize by definition. There is the higher power view showing you the cytology, how uniform it is, not a pleomorphic tumor. And there is a diagnostic marker, nuclear beta catenin, which we'll mention again later. Now, the intermediate rarely metastasizing group is large, and there are examples of these tumors within each differentiation category. I'm not going to go into these in great detail, but some of them will be mentioned again later in the specialty tumors, the specialty presentations, the pattern tumors that we'll be talking about during the day. Now, malignant soft tissue tumors, sarcomas. And all we have to do with these is diagnose them and grade them. Very easy, you would think. There are 3 grades, and we'll talk about that too. So these are our goals for diagnosis. Identify the lineage. And remember, they're not always from the corresponding mature tissue. So within fat, you may get a non-liposarcoma, and you can't define cell of origin, as I've mentioned. But the goals are to assess malignant potential. And in some examples, we're moving away from benign and malignant and talking about risk assessment. And the type example of that is gastrointestinal stromal tumor, but it may become applied to other soft tissue tumor types. So we need then to predict behavior following from that. This will help to guide treatment, and we may also be called in to assess progress. Is there residual tumor? Has there been a response to therapy? How do we start? We'll always start with the clinical features, and then we'll go on to the gross findings and the histological features after that. The clinical information for soft tissue tumors, fortunately, is not a great deal. You will not be told very much on the request form, and so you may have to find it out. We tend not to write on the form, is the patient an adult? We tend to find the information we need before we issue the report. It's quite important to communicate with clinicians and get your act together before you make the final diagnosis. Otherwise, you may well get it wrong. So with sarcomas, it's a painless or painful mass, or quite often painless, and ones in the abdomen can grow very large before they're discovered, obviously because of space to grow into, and can be painless. Painful ones often are because they compress a nerve or involve a nerve. And that's the mass effect, which also can cause thrombosis in a large vessel or obstruct the viscus of the intestine. Always be sure there's no significant past medical history of trauma, previous surgery, previous disease, or previous therapy, immunosuppression, lymphedema due to surgery, or a history of irradiation. And also check out the family history for cancer predisposition syndromes, Lee-Fraumeni, neurofibromatosis type 1, and so on. Now, the basic clinical features are age, sex, site, and you also need to know the duration of the tumor, the size, and the depth from the surface. Let's look at those. First, age, and this is because the diagnostic spectrum of malignancies is different in children. And in adults, different age groups have different tumor types. So this tumor in children can have a differential diagnosis of neuroblastoma, embryonal rhabdomyosarcoma, ALL, and Wilms tumor. However, in an adolescent age group, it has a different differential. Alveolar rhabdo, Ewing sarcoma, desmoplastic small round cell tumor, synovial sarcoma, and so on. And then in adults, you have to bring in carcinoma, melanoma, round cell liposarcoma, and in females, endometrial stromal sarcoma. So you do need to know the age and that very basic clinical parameter. You also need to know the site. This is because the depth from the surface is determinant in many ways of the behavior of the tumor. And most benign tumors occur superficially. And also for sarcomas, the site and the depth relate to prognosis. And the three sites obviously are skin, subcutaneous, with or without fascial involvement, and subfascial. And also this is a staging parameter. The behavior actually relates sometimes to the depth of invasion. The atypical fibroxanthoma is a pleomorphic tumor which, if confined to the dermis, scarcely recurs and doesn't metastasize. Yet it looks awful with frequent abnormal mitoses. However, the same tumor, when it invades more deeply into subcutaneous, is called pleomorphic dermal sarcoma because this has metastatic potential, and we'll hear a little bit more about this later. Another example, cutaneous leiomyosarcoma, when confined to the dermis, however atypical and mitotically active it looks, doesn't very rarely metastasize. And these are, it's proposed that these be called atypical intradermal smooth muscle tumors. Whereas once they invade significantly into subcutaneous, they have metastatic potential. What about duration? Well, paradoxically, very rapid growth can often mean something like nodular fasciitis, not so much in a deep tumor in childhood. You'd be very concerned about rapid growth there because of rhabdomyosarcoma and other malignancies. And yet, some high-grade sarcomas, such as synovial sarcoma, clear cell sarcoma, can have a very long history. And the patient can come along, I've had a lump on my foot for 20 years, doctor, I'm worried. Do a biopsy, and it's a sarcoma. And curiously, once they present, it seems to behave more aggressively. So what types of specimen do we take for biopsy or investigation? Well, small or large. Small specimens, FNA cytology, we do not use for primary diagnosis. There are experts who can do this in specialist centers with all the correlation that they have and with the expertise that is built up over the years. But in a way, it's not really necessary because we have core needle biopsies that are very easy to do, that give you tissue with architecture, and which you can repeat if they haven't worked very well. But FNA has a role, I think, in the detection of metastases or recurrence. Open biopsies might be necessary if the needle biopsy is inadequate. You hope not to do it because it can spread tumor. And some resections are small. Some small tumors are resected entirely. The larger specimens, of course, resections or amputations. How do we handle a core? Do not do it like this. Embed one core per cassette because that allows you to use the material to its maximum extent. When all the cores are in one cassette, you cut through them all at once, so you don't have enough tissue left for investigation. You don't need to cut levels if there are several cores. The surgeon has leveled it for you, if you will. And for very small lesions, less than 5, or perhaps smaller than that, you can embed the whole thing in entirety, several blocks. Larger specimens you will weigh and measure, and of course there are now lots of data sets. There's the college data set, the Royal College of Pathologists data set that Dr. Thway and I have authored for, in the UK, and there are international data sets, and other countries have their own, to tell you how to handle and approach these specimens. So we weigh and measure. You can ink the margin. In those days we ink the whole margin, but it's very messy and unnecessary, so we just put a little bit of ink where we're going to take the block. It really helps you when you're looking at the microscope to see where the margin's supposed to be. And we freeze tissue for biobanking. Most molecular investigations can be done on paraffin sections. Describe the tumor and estimate the amount of necrosis, looking for different areas, particularly in fatty tumors, that might represent dedifferentiation. How many blocks should you take? Well, typically 1 block per centimeter, usually to a maximum of about 12, depending on, you've got to sample all the different areas, depending on what it looks like. For margins, the nearest margin is the critical observation. You need to know the distance from that nearest margin to the tumor. It's often just a fascial margin, but nevertheless you need to record that. There is a tendency for surgeons to handle the specimen like a breast excision and put sutures all over the place and ask for different margins. I think this is for a relationship between you and your surgeon to be determined. My view is once you sew it together, the margins are unclear where the edge was, so you just go for the nearest, which is in any case all that's required in most data sets. Always check if there's been previous pathology. This patient has an intra-abdominal mass this year and it's a pleomorphic sarcoma, but some years ago, the same patient had another tumor that was a well-differentiated liposarcoma, so this is now dedifferentiated liposarcoma. So now you have your slide at last, you have a look at it. The first thing is to see where are you, what tissue do you have, and what plane are you in, skin, subcutaneous, fascia, or muscle. Look at the margin. Obviously, this is a core biopsy and will not have a margin, but you need to know if it's circumscribed, infiltrated, or encapsulated. Look for the cellularity, which is sparse, moderate, or high, and look for the stroma as well as the cells. You're going to describe the patterns. This tumor you can see is dermatofibrosarcoma protuberans. It's in the deep dermis here, and it's infiltrating the subcutaneous fat in a honeycomb fashion. When you look at the morphology of the tumor, some tumors resemble the corresponding normal tissue quite closely. This is often the case with well-differentiated liposarcoma, and you need to look around and find an atypical nucleus that gives you a clue that this is not a simple lipoma. Similarly, with vascular tumors, there's often vasoformation, which can be quite prominent as there, or more subtle as here, where there are also solid areas. But that will give you the clue as to the lineage of the tumor. However, in many examples, you do not have that clue. You have only a pattern, and the four major patterns that we see are the spindle cell, the long slender cells, epithelioid, round, plump carcinoma-like cells with cytoplasm, the small round cell with lacking cytoplasm, and pleomorphic, where all the cells differ from each other, and indeed not only morphologically, but probably genetically. How do we approach each of these? Well, let's take a type example of spindle cell tumor, and the low power pattern can give you the diagnosis, or at least strongly suggest it, in many cases. So what we have here, for example, is fibrosarcoma. We have alternating right angular fascicles of leiomyosarcoma. We have alternating cellular and myxoid areas, malignant peripheral nerve sheath tumor. We have evenly dispersed myofibroblasts, same picture as before, in fibromatosis. This is the storiform pattern of dermatofibrosarcoma. This is palisading in a gastrointestinal stromal tumor. And then there's a whole subset of myxoid tumor. So this is an intramuscular myxoma. This is myxoid liposarcoma with a vascular pattern and no atypia. And this is myxofibrosarcoma with thicker curved vessels and scattered nuclear atypia. So straight away, you've made 9 diagnoses, and we're only about halfway through the presentation. Look at the nuclei next, because spindle cell tumors often have distinctive nuclei. Fibroblasts are often slender and long and pointed, or they can be plumper. Myofibroblasts typically rather uniform, with small punctate nucleoli, prominent nuclear membranes, indistinct cytoplasm merging with the stroma. Smooth muscle has blunt-ended nuclei with paranuclear vacuoles and lots of cytoplasm, and nerve sheath tumors have wavy or serpiginous nuclei, which often pointed at one end and blunt at the other. You can call them suppositories in France, bullets in America, or spearheads in England. Synovial sarcoma also has very distinctive nuclear morphology, with overlapping nuclei, apparently overlapping because there's lack of cytoplasm, and also a very uniform, slightly speckled nuclei with prominent nuclear membrane and no nucleoli. So this gives you quite a lot of information before you even start to go any further. Fibrohistiocytic is a term that's been removed from sarcoma, but is still retained for benign tumors, cutaneous fibrocystocytoma, plexiform fibrohistiocytic tumor, and so on. And this is then the cytology of these is like in the cutaneous dermatofibroma with ovoid cells, somewhat randomly arranged or in a styrofoam pattern. And these are actually fibroblastic and myofibroblastic. So you might have a lineage, but how do you decide whether it's benign or malignant? Well, synthesis of factors, pleomorphism, atypical mitosis, and necrosis, but these vary according to the lineage, so you have to make the diagnosis first, at least what type of tumor is it. So pleomorphism is, of course, common and actually definitional in undifferentiated pleomorphic sarcomas, complex karyotypic tumors. But it's rare in translocation-associated sarcomas because all the cells have the same karyotype. So low-grade fibromyxoid and Ewing sarcoma, and synovial sarcoma are all malignant neoplasms, two of them aggressive, and yet they have no atypia because they're very uniform, which is itself a clue for translocation-associated neoplasm. On the other hand, benign tumors can have marked atypia. Atypical schwannoma, symplastic leiomyoma, and atypical cutaneous fibrocystocytoma can all show these features, and they do not in themselves denote malignancy. What about mitoses? Well, the presence of mitoses alone is not a feature of malignancy. It's often frequent. There are often frequent mitoses in benign or reactive conditions such as notoid fasciitis. We have an arbitrary cutoff of less than 5 to 10, but you can see more. Malignant tumors have usually more and have abnormal mitoses, and that's always a red flag warning sign if you see abnormal mitoses. How many mitoses should you count? Well, per 10 high power field, which is now usually 2 square millimeters on the average microscope, you need to work it out on your own because this is now a requirement to express mitoses in this way. And it's also a grading criterion, the number of mitoses. So we count them per 10 or per 2 square millimeters. But in some tumors, per 50 or 10 square millimeters is required to determine whether the tumor is likely to be malignant. So there are no shortcuts in soft tissue pathology. So what do we do next? What extra techniques do we have? Well, of course, we now have highly sophisticated molecular investigations. This chart just shows you how these have been added and gradually accumulated over the years. We still do, of course, immunohistochemistry. I'm sorry, that's misspelled. And, of course, electron microscopy has been and gone. But notice the bedrock that holds it all together is light microscopy. The H&E slide is the summation of all the molecular changes. Let's have a look at how we apply these to soft tissue. We'll start with immunohistochemistry. With our 4 patterns of undifferentiated or apparently undifferentiated neoplasm, we have different potential panels. We do not use all the panel in each case. We will select from these panels, but more than anything, perhaps, this is to remind me or you of what is available and what we should think of in terms of differential diagnosis, and you may have your own panel that's bigger or smaller than these. Some antibodies are specific in the sense that they are helpfully diagnostic for their tumor type. So beta-catenin for fibromatosis, STAT6 for solitary fibrous tumor, MUC4 for low-grade fibromyxoid sarcoma, and so on. We're starting to get at the bottom here SS18, SSX fusion-specific antibodies. So we're getting antibodies now related to molecular events, which can potentially be extremely useful and specific. Remember that when antibodies are negative, they can also be very useful. So loss of iron I1, loss of trimethylated H3K27 or SMARCA4, the BRG1 antibody, is highly significant. A negative can exclude a tumor. So negative STAT6, because 99% of solitary fibrous tumors are positive, if it's negative, it's probably not an SFT. Similarly with TLE1 and similarly with MUC4, although a subset that are negative have now been described, and I'll be talking about that later. Note the distribution of immunoreactivity. Cytokeratin is widespread, usually in an organ-based tumor, or particularly in an organ-based tumor, suggests carcinoma, whereas if it's very focal, it's more like sarcoma, such as synovial sarcoma. Another example, beta-catenin in fibromatosis has to be nuclear If it's in the cytoplasm, it is negative. And one more, ALK, if it's cytoplasmic in inflammatory myofibroblastic tumor, that's the usual translocation, but this distinctive ring pattern around the nuclear membrane suggests epithelial and inflammatory myofibroblastic sarcoma. Remember, no marker is 100% sensitive or specific. It might start out as such, but it finishes up as not such. Do not rely on a single marker unless the appearances are so striking that you just want to do it for confirmation, for example, fibromatosis and beta leukemia. Don't order every single antibody unless you know why you're doing it, and you ought to know how to apply the result once it comes back. Select your panels, look for the compartmented staining, and note the negative as well as positive findings. And remember this, when you rush out to buy new antibodies, antibodies start out as highly specific and sensitive for one tumor type. They're occasionally positive in similar tumor types, and they're often positive in different tumor types. And then finally, it's used only as part of a larger panel of antibodies. And then finally, it's in the bin. So essentially, these things come and go, and we need to take a view. And do you buy a new antibody straight away? Generally speaking, most people don't get them anyway in these difficult times of financial constraint. But usually it's best to wait a little while until an antibody has proved its worth before you add it to a panel, and hopefully the new antibody will displace an old antibody on your panel. That tends not to happen, and like lymphomas, the panels just get bigger and bigger. Now, molecular diagnosis is becoming almost routine for soft tissue work, and in some respects essential, particularly pediatric small round cell tumors. When should you do it? To make or confirm a diagnosis, when you require predictable prognostic molecular factors, and to guide targeted therapy, you will often be asked to do this by the clinician, by the oncologist. What are the molecular abnormalities in soft tissue tumors? Well, three groups, mainly translocations, non-translocation single gene abnormalities, mutations or copy numbering abnormalities such as MDM2 amplification, and a large group of tumors with complex unbalanced karyotypes, which are the pleomorphic sarcomas for the main part. Translocation-associated tumors. So a translocation is where two pieces of different chromosomes switch over and fuse to the other chromosome and form a new gene where the fusion occurs. This accounts for at least a third of sarcomas now, increasing numbers. It can be a balanced or unbalanced translocation. They're mostly non-pleomorphic because you end up with the same number of chromosomes and every cell is the same. And the non-random ones lead to the new fusion gene, and these genes often affect transcription or function of the cell or as a growth factor. And this knowledge of this allows the targeted therapy. Very many tumors now have rearrangement. So for malignant soft tissue tumors, going alphabetically, this is the first screen, this is the second screen, and you can see there are a lot of tumors, and that many tumors have different rearrangements. But a genetic abnormality does not imply malignancy, because benign and intermediate soft tumors also have single gene abnormalities or fusions of their own. And I've left some space here because this is a very rapidly growing field, and probably by the end of the day there will be several more published. But you will have noticed as I went past those tables that different genetic abnormalities occur in tumors of the same lineage or morphology. We mentioned liposarcoma earlier, also fibrosarcoma, myofibroblastic tumors, and of course small round cell tumors. And you will also have noticed that the same genetic abnormalities can occur in completely different tumor types. So there are some fusions listed there, and even single gene abnormalities, EWSR1, can be found in lots and lots of different tumor types, and I'll be talking about that in a separate presentation later. What techniques do we have? Well, the two standard techniques we use for investigating sarcomas are FISH, fluorescent cytohybridization, which can detect the gene rearrangements and also gene amplifications, and of course RT-PCR, which can identify specific fusion transcripts and allow mutation analysis. This is being augmented and in some place is replaced. Oh, sorry. Oh, so sorry. I was just trying to hide that message, but I think we're okay now. Being replaced by next generation sequencing, various techniques of NGS, principally with RNA-based fusion panels, which allow us to identify fusions, including new ones. And this is why these tables are expanding so dramatically. So starting with FISH, this can detect gene rearrangement, and you use break-apart probes to, excuse me, one on either side of the breakpoint with different colored fluorochromes. So the red and green move apart, and the other alleles stay together. So, and then also for amplification, this is MDM2 amplification, and you can see multiple copies of the gene are shining forth there on the image. There are problems with FISH or limitations. It's a sensitive but not wholly specific technique because genes can partner with multiple other genes. We've mentioned EWSR1, and we'll talk about USP6 later. And this is an example of USP6 rearrangement in nodular fasciitis. That's fine, but it's also found now in lots of other different tumor types. And as for EWSR1, this is so ubiquitous now in both soft tissue and non-soft tissue tumors that it cannot fit on the screen. So what about PCR? Well, this is for detecting transcripts, mRNA, and you can see here that we run it alongside controls and so forth. And I'm not going into the technicalities, but this is specific, but you have to know what you're looking for. And it can't detect uncommon or unknown fusions. It's technically less satisfactory. There can be problems with RNA extraction. And also, once again, there is promiscuity of fusions. In other words, you can detect a fusion, but it is not necessarily specific for the tumor you hoped it would be. So here is another table showing you some fusions which themselves can be seen in many different tumor types, including not only sarcomas, but also hematopoietic neoplasms and carcinomas. So you must always take everything in the context of the case itself. What else can you do with NGS? You can do gene signatures. Oh, that's more like sorry, gene expression profiling. You can identify molecular events that we've mentioned, and of course, the fusion genes are what it's most commonly used for. You need to know a little bit about it, but if you work in a place with a good lab or you have access to it, the excellent scientists who perform these tests will present you with a very good analysis and often a literature search that they have done of what the result means. And this is particularly relevant for newer fusions. This one is collagen 1A1 and PGF-beta, which is just for dermatofibrosarcoma protuberans. Well, we're getting additional approaches coming in, gene expression profiling, and these can help identify new antibodies and also to predict behavior. CGH can be used for copy numbers, and epigenetics has a role, an expanding role perhaps. We're looking at methylation and also proteomics, protein expression profiling may come in. These are not usually yet part of routine workup of a case, but I mention them so you'll know what's coming in the future. But again, always interpret molecular findings in the context of morphology, immunohistochemistry, and clinical features. Now, finally, how do we predict behavior? Is this our job? Yes, I'm afraid it is. And the thing that matters here, not only the age, site, and size, and the other points I've mentioned here, but the most significant feature for predicting behavior in sarcoma is grade. The grading system recommended by the WHO is the French Cancer Center's grading system, which is a 3-step system. It's a differentiation score that is not well, moderately, and poorly differentiated. It is tumors that resemble normal tissue, tumors that are a definite type, and tumors that are pleomorphic or undifferentiated. In fact, the differentiation score is assigned by use of a table that is in the previous WHO book of soft tissue tumours, but not the current WHO. So you may need to look back if you need to have a look at this table. Mitotic index per 10 HPF, which is 2, for me, 2 square millimeters, and it's divided as 0 to 9, 10 to 19, and more than 20. It's very nice when I see a second opinion case and somebody says there are 47 mitoses per 10. Well, it's good. I don't go beyond 20 because that's the parameter, so I stop at 20. Necrosis should also be estimated on the gross specimen. So no necrosis, less than 50, more than 50%. Very crude, but it is the measurement required. You add up the numbers and you get 3 grades. 2 to 3 is grade 1, 4 and 5 is grade 2, and 6, 7, 8 are grade 3. There are some caveats here. The tumours which are always high grade are listed here: rhabdomyosarcoma, Ewing sarcoma, and so on. And some tumours we're asked to grade by the clinician, but it doesn't really correlate with the outcome or behaviour. And often they change their grade on recurrence. These are angiosarcoma and MPNST, malignant peripheral nerve tumour. This is a picture of low-grade angiosarcoma, if you like. I'm sorry, I should say well-differentiated angiosarcoma, which would be low-grade, but which can recur in a very aggressive fashion. It's been proposed that molecular features be used to predict behavior, and one of the schemes suggested by the French group mainly is this SynthARC complexity index in sarcoma. This uses a gene expression signature of 67 genes, which you need frozen tissue, at least at that time, or you can do it on RNA sequencing in paraffin. And this can predict metastasis in leiomyosarcoma, undifferentiated pleomorphic D. diff liposynovial. And this may have some role in the use of small molecule inhibitors. This is still being developed, but it's perhaps a harbinger of the way things are going, that we're going to grade by molecular or with the input from molecular findings, which are also, and I'll mention this again later, affecting classification and nomenclature of tumors. So the take-home message is the clinical context is critical. Always get hold of everything you know can. And that might include the imaging. If you don't have access to the imaging, at least look at the report or ring the radiologist. Methodical approach, as I've outlined. And remember, not everything in soft tissue is mesenchymal. Thank you.